Okay then, welcome to everybody here. We haven't got too many people on board today, so it's going to be quite nice and cozy between us today. For those of you who don't know me, I think I'm looking at everybody else, and I think you all know who I am. I can see it from your participants. My name's Declan. I'm the professional services pharmacist at Pharma Plus, and welcome today to our monthly webinar, which will be on a specific part of asthma, which is the inhaled corticosteroids. There is a reason why I'm concentrating specifically on this particular area, and we'll come on to that in a bit as well. Suffice to say that it is probably one of the most important areas that the Department of Health and many primary care trusts are looking at the moment, primarily because of the expense, but also because of several safety issues, and we'll go on to that in a bit as well. It is going to be recorded, so just bear that in mind when you're asking questions. What I tend to do, I tend to ask you to type in a question in the chat box, which is normally located in the left-hand, right-hand corner of the tool that you're using, or the WebEx tool. And what I'll do is I'll have a quick read through it, and I'll stop and unmute you, so at least that way you can talk and so forth. And at the end of it, we'll unmute everybody. We can have a little discussion if that's what you want. But it is quite a cozy group today, so hopefully we can have some good interaction at the end of it as well. So that's the introduction about it. So I'm going to get on and make a start on this particular presentation. And by the way, I'm not using PowerPoint anymore at the moment. I tried to make it a little bit more dynamic, but what I realized as well is that it tends to sort of swing quite a bit. So if any of you get travel sick, do let me know, and what I'll do is I'll stop using this particular platform and I'll go back to PowerPoint. But you'll see what I mean when I scroll through it as well. So do let me know if you want me to change it. Anyway, let's make a move then. So the agenda for today. So what we're going to do is we're going to go over the basics of asthma, and we're not going to go over it in too much detail itself. But we're going to. I'll probably expect that most of you. I'll be teaching you to suck eggs if I went into too much detail. But I'll go over briefly what asthma is. I'll go over what inhaled corticosteroids are, why they're used in asthma, and why the NHS has used them in their targets for medicines management. There's going to be a reasonable clinical component in it, and we'll end also in what you can potentially do as a pharmacist as well, after the sort of discussion that we've had. Oh, by the way, before I carry on, we are probably going to finish off, I would expect probably about 8:30 to 8:45 today. It's not a huge topic, but we might finish off a little bit earlier today. So that's what the agenda is for today. So moving swiftly on. What is asthma? Well, there are various definitions of it, but this is the main one. And I'm really just going to read it through. So it's really a disorder of lower airways. It's related to bronchial hyperresponsiveness. In other words, the lower airways itself is very, very reactive to certain triggers. And it's also followed by an airflow limitation. So in other words, that's the reason why you get the classic wheezing, because the air is actually having trouble coming in and out of the lungs itself. And ultimately, it is a state of inflammation that, if left uncontrolled, will result in the persistence of symptoms. So in other words, it's very important that you control this. So, sorry, my daughter just walked in and just got told off by my wife. So if you did hear a little child in the background, that's that. Anyway, so that's really what asthma is in a nutshell. I'm not going to dwell upon that. And in terms of the inhaled corticosteroids, they work by a variety of different mechanisms. So, for example, for those of you who did pharmacology in your degree and can actually remember it, and I know I can't remember half the stuff I did in my degree for various reasons, these are generally the way in which the inhaled corticosteroids work, and they work in several different ways. The first thing it does, it actually promotes a transcription of genes that decreases inflammation. So in other words, it switches on particular elements within the body which actually reduces the inflammation. And converse to that, what it also does is that it inhibits a transcription of genes that promote inflammation. So you've got a two-way response. You're actually reducing the inflammation by stopping those particular genes which cause inflammation, and vice versa. And the other thing it does is these two here. It actually decreases the smooth cells hyperresponsiveness to beta agonists and increases the number of receptors. So in other words, with this in mind, if you look at things like serotype and Ventolin and all these other little beta agonists, it actually works in conjunction very well with the inhaled corticosteroids. So that's the reason why you've got a combination of two particular drugs together, the LABAs, which is the long-acting beta agonists, as well as the inhaled corticosteroids. So in a nutshell, what it does, it increases the responsiveness to beta agonists, and it decreases inflammation. So it does two main things. So hopefully that gives you a bit of background on what inhaled corticosteroids are. And by all means, if I'm going too fast, or if you really want me to go over that again, just stop me and by typing on the chat, and we can have a little discussion on that as well. And I can repeat myself. Okay, so that is really how inhaled corticosteroids work, by two main mechanisms. Basically, the beta agonist type mechanism and the reducing of the inflammation as well. So, what types of inhaled corticosteroids are available? Now, I'm sure you know this. If you look in the BNF, you'll be able to see several different types of inhaled corticosteroids, and there really isn't a huge difference between them. And we'll go over that in a little bit more detail later. So if you do look in the BNF, you'll see a few. These are the main ones. You've got beclometasone, you've got budesonide, so that's the thing which is found in Symbicort. You've got fluticasone, which is the same sort of thing you find in serotype and fixotide, and you've got mometasone as well. And also these products are available in combination with beta agonists as well. There is actually a special case of Symbicort, which we'll briefly touch on. I'm not going to go over it in a minute. I'm not going to go into too much detail, but it's something called SMART. And we'll briefly touch on that a bit later as well. But as a whole, these are sort of things you'll tend to find. Now, if you look at the British Thoracic Society guidance, and if you want a copy of this, I'm happy to sort of like send it to you by email. They do a very, very good representation of this. So I'm going to just bear with me a minute. I'm just going to sort of try to do that. Here we are. So what we're really looking at is step 2 at the moment. So you're adding an inhaled corticosteroid, and also what we're trying to do as well is we're looking at step 4 as well, when you actually consider increasing the steroid inhaler as well. So the main areas that you really want to look at is this area here, and step 2 and step 4. So for an adult, which is really what this particular chart relates to, and I'm sure you've seen something similar to this, we're looking at this bit here, which is addition of an inhaled corticosteroid at 200 to 800 micrograms per day, but the higher doses tend to be in this particular area here. So we can increase the dose of the steroid up to 2,000 micrograms a day, which is a huge amount of inhaled corticosteroid, and you'll see the reason why in a bit. So keep that in the back of your mind, and this particular one is for adults. So in terms of children, oops, sorry, too close. This particular one is between the ages of 5 and 12. You're not really going to get inhaled corticosteroids for anybody under the age of 5 unless there's some sort of specialist involvement. But again, step 2 and step 5. Step 2, you'll be adding in approximately 200 to 400 micrograms a day, which is roughly half of what the adult dose is, and that's and when you go to step 4, you're looking at a maximum of 800 micrograms a day. This is the actual strength is in units of beclometasone, not any other sort of inhaled corticosteroid. So what we're talking about here in this particular instance is an inhaled corticosteroid up to 800 micrograms a day of a beclometasone equivalent type of inhaled corticosteroid. So hopefully that makes a little bit of sense. So going back again, I'm just going to quickly, so here again, just to recap, we've got 2,000 micrograms a day maximum, okay, and here we've got 800 micrograms a day maximum in a child, okay, and this is beclometasone equivalent as well. Now, this is where we start getting quite clinical as well, and we start going into things like equivalent doses, and this is quite important to bear in mind because most of the inhaled corticosteroids, and actually practically all of them, really are no different than one another in terms of the actual effects that they produce. So, for example, 400 micrograms of beclometasone as Clenil is the equivalent of about 400 micrograms of budesonide, is also the equivalent of 200 micrograms of fluticasone, and this is really, really important. We'll come on to this in a bit more detail later. It is actually microgram per microgram twice as strong. So the fluticasone is twice as strong as beclometasone, and this is quite an important sort of like thing to understand as well. So, for example, 2 puffs twice a day of fluticasone is the equivalent of probably 4 puffs twice a day of beclometasone as a Clenil. And also you've got the quick QVAR as well, which is 400 micrograms of Clenil is the equivalent of 200 to 300 micrograms of QVAR as well. So again, the QVAR dose is very similar in potency to the fluticasone dose. So even though it's the same drug, beclometasone, something for you to bear in mind as well. They're not equivalent in terms of the potency. So so there is a little bit of variation there, but the actual steroid itself works in the same sort of way, even though the actual dose might have to be changed. Now, as we spoke about earlier, there are standard doses and there are higher doses, and we'll quickly recap on this again. For a standard dose of an adult, it is 200 to 800 micrograms a day of beclometasone equivalent. For a child under 12, but older than, so a child under 12, a standard dose will be 200 to 400 micrograms a day. For higher doses, you're going to get 800 to 2,000 micrograms of beclometasone equivalent, and in a child that between 5 and 12 only is between 400 and 800. So I keep on going on about this, and there is a reason behind it, which we'll come on to in a minute. Okay, so so hopefully that gives you a little bit of background as to the potency of different steroids. Remember, fluticasone is twice as strong in terms of a milligram per milligram dose to beclometasone. Now, what are the safety issues here? Now, this is the whole point of the presentation here. Now you've got a very good idea of what inhaled corticosteroids are. So what? You know, why am I going on about this? And there's quite a few things here. There are minor things, I'm sure you're aware of. There's oral candidiasis, there's dysphonia, which is basically hoarseness of the throat. You're having trouble talking. These are very minor things, okay, and you can probably experience these at quite low doses of inhaled corticosteroids. However, and this is where we start getting into the meat of it, there are some major systemic effects. In other words, there are major issues as well with inhaled corticosteroids if you take it at a high dose. So, coming back to it, if you have doses of 800 micrograms equivalent in an adult or greater than 400 micrograms of a child, you can potentially get these sorts of things. So, adrenal suppression, growth failure, decreased bone density, cataracts, glaucoma, diabetes, and there's a number of other things as well. Now, when you hit around about 1,500 micrograms equivalent of beclometasone, there can potentially be marked adrenal suppression. And one thing I want you to note about this is, remember we said earlier that fluticasone is double the strength in terms of microgram per microgram dose of than beclometasone. The 1,500 micrograms is actually the equivalent of 750 micrograms of fluticasone. Now, if you think about it, you've got various strengths of flixitide inhaler or seretide inhaler. For example, I'm sure you've seen prescriptions with 500 micrograms of seretide, okay, at one puff twice a day. One puff twice a day is the equivalent of 1,000 micrograms of fluticasone, which is the equivalent of 2,000 micrograms of beclometasone. So these are the sorts of prescriptions that you really do need to watch out for. And hence the reason why, just put this in red, is, you know, you're very likely to see these sorts of prescriptions in your practice as well. So what does the MHRA actually say about fluticasone as well, and inhaled corticosteroids in general? What it actually says is that doses above 500 micrograms twice a day of fluticasone, bearing in mind as well that we could actually say it's 1,000 micrograms twice a day of beclometasone as well, should only be used in patients with severe asthma showing some benefit and initiated by a specialist. Now, I've been in a number of GP practices in the past, doing a number of different audits, and I have seen prescriptions at this sort of dose which haven't been initiated by a specialist. Now, you wouldn't know about this in a community practice point of view, but it's something for you to just bear in mind. So when you see prescriptions for huge doses of fluticasone, some alarm bells should be going off, and you might want to ask the patient, you know, have you had a checkup? Do you see a specialist? Those sorts of things with them. And they should really have a steroid card as well. Now, if the child is on the maximum dose of inhaled corticosteroid and not controlled, even with other therapies, they must be referred to the specialist. And the reason why this has occurred, remember we spoke about decrease in growth, so the growth needs to be monitored, and also we need to check that the child, and you need to check a child which is taking inhaled corticosteroids if they're presenting in shock or has a decreased level of unconsciousness, because that could be first signs of adrenal insufficiency or adrenal suppression. So quite a lot to take in there. So really, sort of like summing up the past couple of slides, what we're saying is that anything above 1,500 micrograms of beclometasone, you can start to see some marked adrenal suppression, which is not good, and that is the equivalent of quite a small dose of fluticasone. And this is really what the MHRA actually says, again, 500 micrograms twice a day of fluticasone. Now, why has all this come about, and why am I going on about this? And this is really what brought it up. We sent this link to everybody who was invited to the webinar to actually have a look at this. And I'm not sure if you had a chance to look at it, but it might be worthwhile just quickly going over it. So really, what it actually says is that this poor girl, this was actually in 2001 by the look of it as well, died because, and I just want to highlight one particular thing, died because she was given 5 times the licensed dose of fluticasone. And basically it caused adrenal insufficiency. And that's the reason why I'm harping on about this, because it's very easy to actually do and to actually overdose on this. And what you don't want is this sort of thing on your mind. Okay. Now, what GPs or what should pharmacists or people involved in medicines management do about this? Yeah, I've told you about high dose of fluticasone that can cause adrenal suppression, all the other manner of nasties. What should be doing? What should be done? Now, basically, there's something called stepping down. When you're on a high dose of inhaled corticosteroid, what really should be doing is that you should be stepping down on treatment. In other words, you should be going on to the lowest dose of inhaled corticosteroid that can be used to suppress your symptoms. And a lot of the time, as you can see in my second statement here, it's not completed. In other words, there's a lot of patients out there who haven't been stepped down, who are taking a very, very large dose of inhaled corticosteroids. And you can see for yourself on the previous slide what the devastating consequences of this could potentially be if you don't step down. This girl, obviously, the poor girl died as a result of it, and with an increased awareness, it could have been avoided. And And I said that's the reason why stepping down is so important. Now, how do you step down? Now, really what should be going on, and this is something that you may want to consider in your MURs as well, is asking the patient whether or not they have regular reviews at the GP practice. I mean, almost certainly now that they will have, because they've introduced things like asthma registers and so forth. And really, if you're on a high-dose inhaled corticosteroid, you should really be considering a reduction every 3 months or so. When this happens, there's no fixed way of actually doing this. There's various theories, but generally, as a rule of thumb, what you would tend to do is reduce the dose between 25 to 50% at a time. So if you're on 1,000 micrograms of beclometasone, you may want to reduce it by 250 and see what happens. Does the patient respond well to that, or do they start getting a little bit of wheeziness, in which case you can increase the dose a little bit more after that. So that's really what a GP practice or an asthma nurse would tend to do when stepping down on treatment. They'll start you off. After 3 months or so, they'll reduce you again and test the boundaries of that again, and so forth and so forth. Now, this is where your role as a pharmacist could potentially be used as well. You could ask your patients whether or not they've actually had these reviews, how long they've been on these inhaled corticosteroids for, and whether or not they've actually been trialed for step down as well. And also bear in mind the fact that considering the sort of issues that have cropped up in the past, have they actually got a steroid card, and are they aware of the potential issues regarding high-dose inhaled corticosteroids? And as I've harped on about earlier on as well, take particular care with fluticasone, because it's not a milligram for milligram dose. It is twice the potency roughly, and hence, you tend to get a little bit laid back with fluticasone as well. So it's something for you to bear in mind there as well. Now, so now that you've got a pretty good idea of inhaled corticosteroids in general and the issues with regards to them, what GPs can potentially do in terms of reducing inhaled corticosteroid use in terms of stepping down a treatment, what does the national type of data suggest? Well, we've talked about QIP earlier on in previous webinars, and this is actually a very, very important area in the QIP itself. It's one of the 13 or 14 areas which has been highlighted as an area that's going to be targeted by the Department of Health, first of all in terms of safety and also in terms of cost as well. You should also bear in mind that Seretide 250, which is the highest evohaler strength, is the most commonly prescribed. And how many times, for example, have you seen Seretide 250 inhaler being prescribed at 2 puffs twice a day for asthma? Bearing in mind that that is the equivalent of 2,000 micrograms of beclometasone, and also therefore on sort of like the highest range that you can possibly get, or you should be getting. The other thing is the issue of combination inhalers. Now, the price of combination inhalers have actually, I think they've come down quite a bit. And they offer patients the ability to take only one particular device instead of taking 2 or 3 different devices, but it does offer less flexibility. And if it offers less flexibility, it might reduce the ability for patients or the acceptance of patients to reduce doses. So, for example, if you're going to be reducing a dose of Seretide 250, you're going to need to possibly consider maintaining the beta agonist component on it at the same level while reducing the steroid component. And you can only do this if you've got 2 separate inhalers. So there is a little bit of a debate behind combination and individual inhalers as well, but it should be made on an individual basis. And also, stepping down is the best method that can produce much of the long-term savings. Simply going from one particular brand to another brand is not really going to produce the savings for the NHS under the QIP. what it is going to produce a savings is the stepping down. So really what we've got here is a situation, which is quite rare really, whereby reducing the dose of a particular drug can actually be very beneficial for the patient, and at the same time can produce a considerable amount of savings for GPs and also the NHS as well. So GP practice budgets, I should say, not GPs themselves, but the practice budget. So it's actually, you can see the logic now, I hope, coming together behind this. Now, I did, this is the last slide, mind you, before I open up the panel. I did actually hint early on about a therapy called SMART. Now, what this particular therapy is, I'm not going to go into it in a lot of detail, but SMART therapy is actually technically known as Symbicort SMART. And if you remember in your pharmacology days and the university days and also the pharmacist days now, the logic dictates that an inhaled corticosteroid should be used on a regular basis, while the Ventolin or something like that should be used on an ad hoc basis when it starts to flare up. What they've discovered is that SMART is actually good on a if and when basis as well, even though it contains a steroid and a beta agonist component as well. So what Symbicort SMART is really a regime whereby a patient can take it as a combination of a regular and a PRN dosing when their asthma plays up as well, which is rather unusual because you wouldn't normally, it's licensed for that, but that you wouldn't actually get that for things like Seretide. It's not licensed for those sorts of uses. So it's something that you might experience. And what you'll see, hold on, I'm just going to go back a few slides. Sorry, if you get seasick, just let me know. Here we go. And what you tend to find is that it's in between. When this bit here fails to work, instead of going on to this bit, sometimes some patients go on to SMART therapy at this level here, at that level 3. So that really is what SMART therapy is all about. Okay, so I'll answer your question in a minute as well. Okay, I'm going to open up the floor to everybody in a second. So I'll do that in a second, yeah? Okay, so the last thing I want to suggest, is mention that SMART therapy is only meant for 18 years and over as well. So that is effectively my presentation for inhaled corticosteroids. And in the back of your mind, I just want you to keep one thing in mind, and that's this little girl here. And whenever you see a prescription for fluticasone for asthma, do bear in mind what the consequences of excessive use actually could be, and this is it. And this is really the reason as to why this particular presentation was done. So I hope you've enjoyed it. I am very, very ahead of schedule at the moment. And what I'm going to do is I'm going to open up the floor to everybody. So if you want to have a chat, I can hear you now. I've got one question here from somebody, and it says, can one do the stepping down and stepping up if symptoms worsen on a frequent basis? And yes, you can. The whole idea is Snake, can you hear me? Snake? Okay, looks like somebody can't hear me. Okay, so okay, you can hear me. I can't hear you though. Okay, never mind. Okay, let me see if I can. No, it's nothing on my computer. Let me just try this. Okay, can you hear me now, Snake? Okay, okay, never mind. Don't worry about it. I've got your okay. I've got your question here. So what the answer to that is that you want to control it first. You want to get a reasonably high dose of inhaled corticosteroid, just enough to control it. And then what you do is you reduce it to the minimum possible dose. If, for whatever reason, the asthma gets worse, then what you can do is you can increase the dose accordingly and in accordance to the response that way. So the idea is you reduce the dose, and if the lowest dose doesn't work, you can titrate it upwards as well. Does that answer your question? No. Good, excellent. Okay, does anybody else have any other questions they want to ask? Now's the time. Okay, I don't think there's anybody else then. Okay, so hopefully, I did try and not waste too much of your evening this time, but I did try and keep to time, and I think I've kept to time as well. So do enjoy the rest of your evening. It will be. Oh, sorry. Here we go. I've got another question here. A lot of times, patients are not sure about using the gadgets. Yeah, that's definitely right, and that's one of the things that you could be teaching them in the MUR as well. So there is that particular element there which you could use. They should know, because the asthma nurse should be reviewing them on a regular basis, and that could be your first indication that a review might not be occurring at the GP practice. So what you might want to do is, if a patient isn't aware on how to use a gadget, that could be the first signs that that they're not being reviewed appropriately at the practice, and that's another way which you can step in as well. Okay, any other questions? Okay, what I'm going to do is I'm going to switch off for now. So hopefully you've enjoyed this, and hopefully you've taken away a few points. If you do take away a point, just if you take 1 point away, then the point that I would suggest is that you think about the titration of the doses, and so the equivalent doses and stepping down. So if you take anything away with you, just take those 2 points away: stepping down and the fluticasone dose, which is half the strength of the beclometazone. It will be on the website probably by next week. So if you do want to watch it again, by all means, go online and do that. And if you want me to give you any of the slides, so if I can see it, so if you want me to give you these ones here, or a copy of that, then again let me know, and I can forward you the document with this on it as well. It's quite a good read too. Okay, so I'm going to switch off for now, and I hope you enjoy the rest of your evening, and I'll see you same time probably next month. Take care now. Bye.